Greetings and welcome. My name is Brad Monk. I'm a gynecologic oncologist. I am here in West Palm Beach, where I am the medical director of late phase clinical research, but I'm really just a gynecologic oncologist. I'm also the vice president of the GOG Foundation and the director of the GOG Partners Organization, which is a nonprofit that works with individuals, sponsors, and also we sponsor our own studies in cervical cancer. So that's what we're here to talk about is cervical cancer. It is a terrible disease, but it's treatable. And most importantly, it's preventable. We have very few cancers that can be both treated and prevented. So I'm going to start at a very basic level. I'll try to sort of provide hopefully something for all of you. This is my disclosures. This is my message. No one has helped and contributed to this. So I'm going to be as fair and balanced as I can. As part of an introduction, I'd like to sort of share with you the difference between pre-cancer and cancer. You'll hear a woman say sometimes, well, I had a hysterectomy for cervical cancer. And then you looked and you see actually the hysterectomy, although appropriate, was for pre-cancer. They're not the same. In order to get cancer, you have to have pre-cancer. And sometimes pre-cancer is called dysplasia or carcinoma in situ, and it's detected on a pap and so on. I want to talk about what the cause of cervical cancer is. It is caused by a virus generally, not always, but over 90% of the time. And if we have learned anything from COVID, if you don't want to die, you should get vaccinated. And guess what? That applies to cervical cancer. We've also learned from COVID that if you want to see if you have it, you should get the test for the virus. Guess what? We can do that for cervical cancer too. So we can immunize or vaccinate a man or a woman against the human papillomavirus, which we abbreviate HPV, so you don't get it. And if you sort of miss that opportunity, then we can test you for the virus to make sure you're safe. There are guidelines in place. I want to go through those. Everyone needs to be protected, but if you get it, we can treat it. And we're going to talk about that in detail. So it was once one of the most common causes of death in the US. It continues to be a common cause of death in other parts of the world. And the reason it's not anymore is because we can screen for it and we can also treat it. So I told you I was going to start basic. It's pretty basic. What's the cervix? So the cervix is here, the entrance of the womb sometimes called the uterus. The cervix is technically part of the uterus. It is what dilates to let the baby out. It's connected to the fallopian tubes. And ultimately at the end of the fallopian tube is an ovary, which creates an egg, taken up by the fimbria, fertilization. Mr. Sperm meets Miss Egg, and then the baby settles here. And when the baby is ready to be born, it comes out the cervix, unless you have a cesarean section. So I get that. So that's what the cervix is. We can do excisions of the cervix. It's in a cone-shaped cone shape. And we can do that with a wire and electricity called a loop excision, or we can do it with a knife, sometimes called a cold knife. And you'll hear us talk about a way to treat precancer with an excision, either with a loop excision, an electrical wire for cautery, or with a cold knife. So what happens is in the cervix, if it gets infected by the human papillomavirus, abnormal cells develop. And if those go unchecked, then it can invade and it can damage normal nearby tissues, local extension, but it can also, the cells can break off and spread to the lymph nodes or spread in the blood to organs such as the liver and the lungs. But we can prevent this, okay? And we can prevent it. These preventative stages, again, are precancerous. They're detected through screening, and we'll talk more about sort of what that means. The human papillomavirus is a double-stranded DNA virus, about 8,000 bases. It is transmitted through intimate contact, skin to skin. most people who get it never know they had it, and it generally goes away on its own. However, you can get it over and over again. It can be dormant and be reactivated. And the only way to make it go away is your own immune system. I can't stimulate, or at least I don't know how to stimulate your immune system to make it be more efficient in viral resolution, but I do know how to prevent it with a vaccination. So HPV infection usually goes away. If it doesn't go away, then it's a persistent HPV infection. Those patients are at risk. And again, I can't really make the virus go away, but I can make the abnormal cells go away through an excision, as I mentioned. Now, almost all individuals that are sexually active are exposed to it. It's so ubiquitous. Again, most people don't know they had it. Most people get over the viral infection. It's those that don't get over the infection, and I don't know why that happens, that are persistently infected, that are at risk for cancer. There are some risk factors for persistent viral infection, such as immunosuppression, HIV, immunosuppressive medications, and certainly smoking. This is one of the cancers that smoking causes. So screening is done by a test and by finding a precancerous area. It can be treated. And the trick here is that a precancerous area can sit there for many years, sometimes as many as 10. So it sits there, we find it, we ablate it, excise it, if you will, through a loop excision or a cone, and then the woman's life is saved. So these are easy to treat early lesions, and if you have a local excision, you can still get pregnant generally. So we used to say pap smear. We don't smear anymore. There's no slide. We put it in a liquid using one of these devices, and the liquid is the what we use to test for the virus. I prefer that a patient has a cyto brush. This brush goes inside the cervix. It collects more cells up inside, and then also a spatula. And this is a combined spatula and brush. This is probably the most common, but I actually prefer a spatula, a collection from the outer, and then an endocervical brush from the inner. You put it in the vial, and the virus is tested for. And so you can test for this. A primary HPV test is the preferred way because if we learned anything from COVID, if you don't have the virus, you're not going to die of COVID. Okay, same here. You can also look at the cells under the microscope that can be isolated from the liquid and do both. That's probably the most common. A co-test, we could argue what the best method is, but HPV testing is the preferred method. And I think we all need to know what our HPV status is, and obviously to know what our PAP status is. And this is now added to mammography and colorectal cancer screening with colonoscopy. These are the recommendations. We don't want women to get screened too early. Why? Because you might find something that's going to go away on its own. Remember, I told you most infections go away on its own. And it's very rare. So don't say, I want to be extra cautious and get screened when I'm 19. Yeah, well, you might find something, and you might end up with an unnecessary procedure because it would have gone away on its own, and you might have scarring of the cervix or even end up with a hysterectomy. And then here, 3 to 5 years, because HPV testing is the best, you can wait for 5 years because, again, it takes time to get the virus, get precancer, and get cancer, plenty of time to pick it up the next time. If someone would ever do a PAP alone, then 3 years, but really co-testing cytology of PAP and as the best. So this is very important. When to stop screening, some controversy. We're all living longer, hopefully, and I'm a fan of keep the screening going, particularly if it's only every 5 years. So it's a multi-pronged approach. Get screened, get vaccinated, don't smoke, and if you could avoid have safe sexual practices. That's not always possible. but it's a multi-pronged approach. The vaccination is safe, period. There's no virus in there. Remember with COVID, there's some mRNA. This is protein. Okay, this is protein. This is protein that you put in your body, even if you're a vegetarian, because there's protein in plants. There's no preservative in there. It's very, very safe. And so HPV vaccination should happen in young people before sexual debut. Generally, it's part of the adolescent vaccine platform, 9 to 12, when they also get a DPT booster and a meningococcus. So even if you get a vaccine, you should still be screened. There's some controversy because if there are some cancers that are not HPV related, but they're rare, but let's get vaccinated, and let's get vaccinated young and often. And this has been approved since 2006. So this is nothing new. Now, if that isn't the grossest thing that I could show you today, this is what a cervix looks like on FOSS looking into the vagina. I've cut this out. Yeah, if that sounds terrible, you're right. So get vaccinated and make sure that everyone that you know is vaccinated when they're young, boys and girls, because yes, even Michael Douglas can get head and neck cancer from HPV, okay? And certainly even Farrah Fawcett can die of an HPV-related cancer. So it protects the vaccination against anal, vulvar, vaginal, cervical, and head and neck cancer. But this is a cancer that a woman that was not vaccinated. This is a woman that did not have a Pap test, and this is a cervical cancer. My trainees call this a cauliflower lesion, and it looks like a head of cauliflower. It's terrible. This is the paracervical soft tissue. These are the ovaries that I showed you. These are the fallopian tubes, and this is the body of the uterus. Now, this is a CAT scan. If you imagine cutting the patient in half and looking from the side, this is the tailbone. This is the normal sized uterus, and this massive thing is a cancer. This cancer is too big to cut out because you'd have to cut the rectum out, you'd have to cut the bladder out, and we can give chemotherapy and radiation as a preferred option. So that is what we call locally advanced cervical cancer. Chemotherapy and radiation is preferred. Smaller cancers can be treated with hysterectomy, and sometimes even very early cancers can be treated with fertility sparing. And then the cervical intraepithelial neoplasia, dysplasia, or precancer can be treated with a cone biopsy or a loop excision, and an under-resourced can either be frozen or burned. If the cancer comes back, we use standard chemotherapy. I'll get into that. Standard chemotherapy generally is platinum. Platinum is a metal, the same platinum metal that jewelry is made of. It can be solubilized, given intravenously. It's very effective, one of the most effective medications to kill cancer. Platinum, carboplatin or cisplatin. It can be added to a second medication, generally a taxane or Taxol or paclitaxel, which is a naturally occurring substance from the bark of a tree. And so it was isolated, and that toxin in the bark of the tree protected the tree from the insects. And so we're able to get platinum and this toxin from the tree bark, the Pacific yew tree, a conifer from the Pacific Northwest, and give it as chemotherapy. And I'll talk about these other medications, an immune therapy and a medication that prevents blood vessels from feeding the cancer. And then there's some other treatments that are more esoteric if the frontline treatment doesn't work, or the second line in the second line. So this is a treatment paradigm that has sort of been my pleasure to work on. That's why I'm here. Another caveat is cervical cancer is more common in minority women, women of color, marginalized populations. Most of my adult life, I've been passionate about this even before diversity was a thing, okay? Because I recognized as a young man more than 25 years ago that we had to treat all comers that were in need, regardless of skin color, language, country of origin, sexual orientation, and so on. So, but it's a thing now, and that's great. And I'm glad that we're on board. I grew up in Arizona, and most of my patients then were Latina. I'm now in Florida today, And I see, again, a very ethnically diverse group here in West Palm Beach. So cervical cancer is different depending on where you live because screening may not be available. So these are the percentage of patients that have locally advanced cancers, cancers that are so huge you can't cut them out with a hysterectomy. And you can see in some of these, Kazakhstan, India, that many of the cancers are too big. We have pretty good screening here, but not everyone complies. So I still see patients that need chemotherapy and radiation because the tumor is too large to have a hysterectomy. If the patient does have locally advanced cervical cancer and needs chemotherapy and radiation, they have a big team. They have someone to do the radiologist. They have a tumor board. They have someone, they have a nurse. They have someone to do the biopsy, a cancer pharmacist, and someone to give the chemotherapy. So this is a team. It's not a sport, but it's a team opportunity, and it's an all hands on deck to get these women cured. The average age of locally advanced cervical cancer that's too large for a hysterectomy is 48, 49. So these are women who frequently have children in the home and deserve our attention. So the treatment paradigm sort of started in 1999, that in addition to radiation, we should give weekly chemotherapy, again with a platinum, cisplatin. This is pretty old now, 25 years ago, published in the New England Journal, and that's the standard treatment. Now, this is a slide to emphasize that when a person gets treated for any malady, you got to go to an expert. Okay, and it's very difficult to know whether that doctor in front of you is qualified. You got to do your diligence. Okay, and in this particular setting, you need to be examined by someone that's skilled. You need a radiologist that knows how to do an MRI. I even put contrast in the vagina. We do, in addition to a pelvic MRI, a PET scan. We don't do surgical staging hardly ever. And we don't take the patient to the operating room to examine her anesthesia because we can, I know it sounds sarcastic, but we can actually examine patients in the office. Okay, but in the olden days, we used to examine them under anesthesia and do these things that are no longer necessary. And radiation is sophisticated now. Radiation now is done with intensity modulated radiation therapy. Each one of these lines is the dose of radiation calculated on a computer delivered to the patient. And you can see in the center of the body is the cervix, and it's intensity modulated. It's intensified where the cervix is, and the area where the lymph nodes are carved out because the lymph nodes are common sites of spread. So this is what a radiation oncologist does. A radiation oncology says, radiate that. And then there's a PhD physicist who programs the computer to make sure that the radiation is delivered in a way, the way the physician, the radiation oncologist, wants it delivered. And then the gynecologic oncologist or the medical oncologist, depending, administers the chemotherapy. So there, as I already told you, the treatment team is extensive. In addition to external beam pointing, beams, energy, you also have to put radiation in the cervix, which is the trick and why cervical cancer is highly curable with radiation. Takes skill. So there will be doctors that say, I don't really do that. I'm going to sort of give more external radiation because I can, and I don't know how to do an implant, sometimes called, and you can see the difference in the survival. I'm going to show you these curves. These are called survival curves. And everyone is alive in the beginning. And then over time, there's percent surviving. And so this is now over time. So this, let's see, is 6 years or 4 years. So you'd rather be on this line. So at, let's say, 4 years, that maybe 65% of patients are alive versus 45%. And the delta, the difference here is 20%. So if you get brachytherapy, you can cure 20% more patients. So you always want to be on the upper line because there's a difference here, and this difference is substantial enough to justify it. And because it's local treatment in the cervix, it has very little side effects because it doesn't cause hair loss, doesn't cause neuropathy. It's given right there, and it's given under a sedation, and it's given in a way for just a short period of time. So you're getting the external treatment Monday through Friday for 5 weeks. And then the implants are put in towards the end of the treatment 3 or 4 times for just a few minutes. And these are the types of brachytherapy implants. This is the most common. The tandem goes in the cervix. These round things are called ovoids, which are next to the cervix. Some individual that was smart said, well, why don't I just make it round to go around the cervix? Someone else said, well, maybe I should stick right into the substance of the cancer, some needles, and put radiation through these hollow needles. Again, this is what radiation oncologists do. And specifically, this is what brachytherapists do, because brachytherapy is a skill. Now, unfortunately, where there is the most cervical cancer, there is the fewest amount of radiation. So these are you see in the US, green, lots of radiation, very few cancers. Here, lots of cancer. Here in Africa, very little radiation. So I just want to point that out because I'm sensitive to the mismatch of resources, and that's really important to note. Now, brachytherapy is not great. I told you it mattered, but you can see even over time here in this California study, there were still as many as a third of the patients who were not getting brachytherapy. And again, if you're ethnically diverse, you have a less chance of getting good treatment for several reasons, economics, and maybe even discrimination, maybe where you live. So again, if you're Black, you might be here, or Hispanic, but if you're white, you may be here, and it's always better to be on the upper curve, and there's about a 20% difference. So what do we do if the radiation doesn't work? That would be called persistent cancer. Again, it persisted. Or what if it's found and it's metastatic, stage 4? Or what if you treat it with radiation, you thought it was gone? That would be recurrent. And we've learned that your immune system wants to fight your cancer, but can't see it. They're blind. Your immune cells are blind to the cancer, so we have to re-educate your immune cells with medications, unmask them, if you will, so they can figure out that the cancer is really trying to kill you, that it's really not you. And that's immunotherapy at its core. And it's complicated with lots of different molecules. There are genes, HPV genes that are there that we can also attack. But this is the trick of immune therapy. And I'm sure if you watch TV, you hear about immune therapy. Immune therapy is approved in more than 15 cancers and more than 30 indications. And cervical cancer is a big one. And I've spent a lot of my career trying to bring immune therapy to women who have persistent stage 4 or recurrent cancer. Now, I've had the pleasure of participating in 6 practice-changing phase 3 trials. I already explained to you that in 1999, cisplatin was added to radiation and increased the cure. Okay, 1999. But I was told that it's not true, that cervical cancer is chemotherapy resistant. Totally not true. And so this was sort of one of my first papers that I was able to work with the GOG, and that's my background, to identify chemotherapy backbone in the recurrent setting for stage 4B persistent or recurrent cervical cancer. That was in 2009. The first biologic or targeted therapy approved in cervical cancer came 5 years later, which was an antibody that bound to the protein that causes blood vessels to grow. I had this epiphany that if there's no blood vessels to feed the cancer, it can't live. You're right. And that medication was called Avastin. Now it's biosimilar, that is to say generic. It's called bevacizumab. We developed that, and that was a benefit. And then came the immune therapy, okay? And this was also in recurrent or persistent metastatic cancer. And then ultimately, We went all the way back and added immune therapy to chemotherapy and radiation. So that's pretty exciting. Now in the second line, I'm not going to talk too much about it, but is what's called an antibody drug conjugate. It's a smart bomb, an antibody that binds to the cancer preferentially because we can identify antigens or proteins that are unique to the cancer. The antibody is given intravenously, binds and localizes to the cancer, and it has on its tail a toxin, a warhead. So it enriches the tumor microenvironment with the cytotoxic agent, and it kills the cancer. And these are miraculous medications. So this is drug discovery at its core: anti-blood vessel, anti-angiogenesis, immunotherapy, and then antibody drug conjugates. So this is a great story. It's not great because it ends up in a medical journal. It's great because it saves lives. It helps women battling cervical cancer live longer and better, and it helps them even be cured if they're in advanced stages. So immune therapy has been a big deal, sort of the granddaddy of them all, the GOAT. Greatest of all time is pembrolizumab. We developed it in the second line in June of 2018. We added it to the first line with chemotherapy with or without bevacizumab. And now just this year, we added it to concurrent chemotherapy and radiation. There are others that are in development that we've studied. They complement the pembrolizumab story. This medication is called Keytruda. We have generic names like acetaminophen and trade names like Tylenol. I get it, it's the same medication. All of these medicines don't have generic yet, but the Avastin does have, and that's called bevacizumab. If it's an antibody, it's not technically a generic, it's called a biosimilar. So this is really what I mean. And so if I could sort of visually represent the idea that we established chemotherapy as a backbone in 2009. Again, when I was a young man, I was told, look, Monk, chemotherapy doesn't work in cervical cancer, and I refused to accept failure. And at that time, patients were not getting treated with chemotherapy. They were living on average age 48, 49, 7 months. And then here comes chemotherapy, standard, regular old chemotherapy. Your hair falls out, you get some nausea, you know what chemotherapy is. And we went from 7 months to almost 13. That's pretty good, not good enough. And all of a sudden we started to shrink tumors, overall response rate, shrink tumors almost 30%. We didn't give up. We added this antibody that causes blood vessels to choke the cancer. And we're able to go from 12.9 months to 17.5 months. And now we're shrinking half of the tumors, okay? And they're living a year and a half. And then we added immune therapy to this. Ultimately, we increased the response rate now to almost 70%, and women are living 2.5 years. And then if you add antibody drug conjugate to them another year after that, we're now 3.5 years. So again, these are averages. Every patient is different, and there are side effects that have to be handled, including hair loss and neuropathy and some things that these anti-angiogenic medications do. And sometimes we stimulate the immune system too much, and we cause your immune cells to attack normal cells, but those are relatively rare. But we've changed women's lives. Why? Because of families, patients, and investigators, and quite frankly, drug companies that see the value of doing this clinical research. And this is what I enjoy doing on a daily basis. So I want to share with you some information in the first line. I just want to run through a clinical trial design that we can do. And again, I told you I was going to show some of these curves, but this is here chemotherapy. This is survival. This is chemotherapy with or without. About 2/3 of the patients can get this bevacizumab, this anti-angiogenic antibody, and you can add immune therapy to it. These are women with persistent cancer, stage 4 cancer, or it comes back. And you can have this delta, this difference of at 3 years of about 30%, okay, by adding as many as 4 medications. It's a lot of work. But look here, there's a plateau here. And this treatment's only given for 2 years. So here at 3 years, you see this plateau, a year off treatment, and the cancer hasn't come back yet. So that's 30, 40%. So now all of a sudden we've taken a cancer where chemotherapy wasn't even used. And in 30 to 40% of the patients, this is a biomarker. This is a biomarker that 90% of patients have, so it's common. That 30 to 40% of the patients might even be cured. Might even be cured. So I'll see a patient says, I don't want chemotherapy. My uncle had lung cancer and died anyways. I said, and what does your uncle who had lung cancer have to do with you today that has cervical cancer? Like, well, he or she, my uncle, he got immune therapy. Again, you have to fight. You can't run from it, okay? You have to fight, and you need someone on your medical team, not someone, but a group of people to fight for you. So this is a great story. I'm going to this is a deck that you can have access to, and I don't want to belabor the point, but these are the details for some of you that are physicians that you can look at. I made this deck, and it can be uploaded from this wonderful organization who cares about you the way I care about you, and it's really been exciting. So I want to sort of reiterate what we've said is that the past was giving chemotherapy. 2009 hasn't been that long ago, 15 years. And then we made an incremental benefit with bevacizumab, which is now biosimilar, that is to say generic. It's much cheaper. And now we can add immune therapy, and there are other immune therapies that are of a similar mechanism of action that we can also use. And in the deck, if you decide to download it and view it, or if you want to talk to me, we can interact. But there are several immune therapies that sort of complement or reinforce that this is a correct principle. So this is the last thing that I want to show you, is because we wanted to add immune therapy to chemotherapy and radiation to cure more patients. It's been a nice journey to see women who are going to die soon, to see that they don't die because they get chemotherapy, bevacizumab with or without pembrolizumab. But here we launched a massive trial around the world with more than 1,000 patients through the GOG. This is GOG Protocol 3047 and the European network, which is called NGOT, sponsored by the maker of pembrolizumab, and taking patients who are getting external beam radiation and brachytherapy and weekly cisplatin, just like I told you, since 1999, and adding pembrolizumab or placebo. We did it, 1,100 patients. We did it, this was presented last year at the European meeting called ESMO, and ultimately we enrolled, finally, diverse patients. So whites, of course, but Asians and Latinas, wasn't that great? And we enrolled patients, and there was a treatment effect, what we call a hazard ratio, a risk reduction of recurrence or death, no matter what the age was, no matter what the race was, no matter how functional they were, what type of radiation they get, or even the stage. Now, all these patients had unresectable disease. Again, cancers that were treated with chemotherapy and radiation because it was too late stage for hysterectomy. And they were randomized on this clinical trial. God bless them all. And half of them got placebo, but the other half got immune therapy. And this led to FDA approval just this year. And it was only approved for the highest risk patients. The paper has not been published yet. So this is right out of the instructions that go to the doctor. So your doctor that wants to use a medication can get the prescribing information that comes from the FDA, and this prescribing information that says that if you get chemotherapy and radiation only, you have about a 50% cure rate. 50% right here. And if you get immune therapy added to it in these highest risk patients, you can have a 20% higher rate of cure. So this is an amazing discovery, having discovered immune therapy in late line, approved in June of 2018, moving it earlier with chemotherapy with or without bevacizumab, and now following our intuition and the science, enrolling a large 1,000-patient trial with chemotherapy and radiation in the curative setting and winning. So this is a testament to the hard researched working staff, the manufacturers where the medication is made, to the families, and most importantly, those that participated in the clinical trial. So this has been updated, and there are even just now, it was approved in January. Now there's a press release just a few months later that said that it's even better. So all studies are looked at by a data monitoring committee just to make sure that everything is safe and legitimate. And the data monitoring committee said, look, we have to tell more information to the world because this is so exciting. And that really is being better in survival. Because what I showed you before was time to progression. This is survival. And so this is great. This is not yet approved in Europe. We're lucky that in the US, our FDA, which is a government agency, just like the FBI and the IRS, they're governed by Congress. And ultimately, they are highly motivated to bring cutting edge medicines to Americans that they can help every sort of illness, but particularly cancer. So this is a press release that's even better than the January FDA approval. So I'm not going to go through this because these are details and I'm speaking more conceptually. But I think that the take-home message is clear, that you can hide from cervical cancer if you want, and that's called a vaccination, okay? But you can't run from it. Once it happens, you have to fight. And the way you fight cervical cancer, if you don't get vaccinated or screened, is to get immune therapy. Now, there are some contraindications to immune therapy. Hopefully, it can be used early on with now recent approval, adding it to chemotherapy and radiation. And if I have another take-home message is that clinical trials are how you get the next best thing. And so hopefully patients are treated at a center where clinical trials are common. And the most important decision that you'll ever make regarding your illness, that is that if you have a serious illness, the most important decision relative to that serious illness is picking your doctor. And your doctor will give you some options, but you don't know what to do. And so you have to rely on the faith and confidence that you have in the doctor that you chose to get the best treatment for you so that you can live longer and live well. And so I hope that you understand the seriousness of cervical cancer. I hope you understand that it is extremely preventable with HPV vaccination, that HPV vaccination is best given before a sexual debut. It is FDA approved all the way up to 45, but certainly it's better again as a kid, and the pediatricians know this, and they give it all the time, and it's a protein, it's safe, okay? The risk of, just anecdotally, the risk of the HPV vaccine, quite frankly, because it's deep in the muscle, is that you get up and you're woozy and you faint and you crack your head. So is it safe? No, because you might get a skull fracture, but you didn't get a skull fracture from the vaccine. You got a skull fracture from the needle. So it's a dangerous world out there. But let's use good judgment, pick the right doctor, get vaccinated. And if you missed a vaccination or if you're over the age, let's get screened. And the best way to get screened is test for the virus, which is what we also learned from COVID. So thank you for having me today. I'm right here. Florida Cancer is the largest single practice of oncologists, I think, in the world. We have 98 offices. We have almost 260 physicians. We see almost 3.5 million patients. Can you imagine? A year? Over 100,000 unique patients. And again, I'm very passionate about diversity. I would not want to work in an ivory tower, as they say. I don't want patients to have to drive several miles to see me. 65% of Floridians live within 20 miles of one of our offices. Neighborhood. And so my job here in Florida is to bring now clinical trials to these offices, because you can get a clinical trial in the community, and that really is what's important. Patients are satisfied, 88%. Score is exceptional. We see patients on time. No one should have to wait for cancer care. And again, we have access to clinical trials in our network. So thank you for having me. I know you're busy and have a lot to do, but hopefully this resonated with you at some level, either from a treatment standpoint or a prevention standpoint, or simply just coaching, that if you get a serious illness, make sure you pick your right doctor. Thank you for having me today.